to all of you. So, welcome once again to the live stream YouTube channel of Department of Urology, Savai Mansingh Medical College, Jaipur. Today, we are having a workshop on HOLEP, and we are really privileged to have with us today one of the finest HOLEP surgeons, Dr. Pankaj Maheshwari, with us. So, we will be starting the case soon. And I will just let you know about the patient. Our resident will just let you know. And in the meantime, I will just, Dr. Pankaj, you are on the YouTube, right?
Morning, sir. Thank you very much for this kind invitation. It's a wonderful department and extremely happy to be here.
Thank you. Thank you, sir. So just give a small description of the patient and then we'll start.
So the patient presented with retention of urine, and on examination there is a grade 2 to 3 firm prostate with 82 cc prostate, and the PSA is 2.8. So the patient has been taken up for HOLEP.
Size of the prostate?
82 cc prostate.
Right. So this is 82 cc of prostate, and now we would be working with Richard Wolf instruments, right? Richard Wolf instruments for HOLEP, and a laser we have from Jena. So we have the main person from Jena, Dr. Pillai, with us.
I'm Ishwar Pillai. So looking after the applications for Jena laser. So now we are going to start with the HOLEP procedure. So we have the settings, everything ready.
So this is the machine, Jena machine, and the settings are. Have you said the
Yes, sir. We have for enucleation the setting is 50 hertz and 2 joules, and for coagulation we have kept it at 30 hertz and 1.25 joules. So here we have the
Just show the settings.
Here we have the advantage with our Jena laser is that we can modulate with the pulse also, like we can shift from short pulse to long pulse. So now we have kept it as a long pulse, as it helps a lot of advantages with hemostasis also. So that's why we are going to start the enucleation with the long pulse at the prefix settings.
Okay. So,
So Dr. Pankaj is going to start the case. So he
sir,
is.
मॉड्यूल थोड़ा सामने आ सकता है?
So put it here.
इधर भी आओ, इधर आओ. And मैडम टेबल थोड़ा नीचे जाएगा. सर, कर दीजिए मैडम, और नीचे कर दीजिए, और नीचे कर दीजिए. बस, that's good. फाइबर दे लो.
Yeah.
Okay. So for the sir, I'll keep on talking for the
Yes,
students.
please.
Yes. Sir.
Excellent, sir.
Now, whenever we are doing HOLEP, let's look at few landmarks. Okay. So obviously that's the Vermontanum. Okay. Does not look 85 gram gland, probably 40-45 gram gland. Now two very important landmarks here are the groove between the Vermontanum and the lateral lobe. This area. This area. And again similarly this area here. If you know that the capsule is the thickest and most superficial just in front of the Vermontanum. So we will try to identify the capsule at this level. The plan will be to identify capsule here and then remain for the dissection on the capsule. So I will be taking the first incisions by the side of Vermontanum, then joining those two incisions in front of Vermontanum, go under the median lobe as much as we can. There will be a limit to how much you can go because the adenoma is attached on both the sides here. So beyond one place you will not be able to go under the adenoma. Stop there. Then take the one or two midline incisions. So in this patient, because the median lobe is not very big, rather there is no median lobe, just elevated bladder neck. So probably I'll take a single incision in the midline. Otherwise, what you can do is there is always a preformed groove. In most of the large lobes, you will find a preformed groove. So take the incision in that groove. Because the adenoma is already elevated on this side, there is no risk of overshooting. So you just cut and then deepen till you reach the capsule. So like, एक हमको 5 French ureteric catheteris. 5 French. Okay, again sir, for HOLEP, what is ideal is that you should see the complete circle. ये जो हमारा laser guide है, that means I should see the laser fiber the moment it comes out of the laser guide. अभी इसमें ऐसा होगा because I can't see the lower end of the, so the laser fiber will remain slightly protruded. Now if it remains protruded, there is a bit of vibration in the laser fiber. So if you work just beyond where it comes out of the laser guide, then the vibration is not there.
That's why you are using UCAT in this case.
Yes. Oh, अरे वाह, वजन ऑन है सभी वेरी गुड. सर यहाँ से आपको नहीं जाना.
यहाँ जाना नहीं है, लेजर फाइबर का ध्यान.
नहीं, ये लेजर फाइबर खींच जाएगा. So always I prefer to keep the machine touching patient's left leg. So then nobody goes between the.
हेल्प करो. Yes.
डाली इसमें से लेजर फाइबर डाली. सिस्टर अब आपको ऐसा घूम के आना पड़ेगा. हाँ जी, डालते जाओ. Going comfortable, है?
Yes.
जा रहा है? नहीं जा रहा? हाँ, आगे. पीछे ले लो. पीछे लो. It should just be visible. Just visible. पीछे बस perfect. Okay. So now, okay, a few more things is table needs to be significantly down. Means I really do not want to elevate my shoulders up. नहीं, flat ही रखिए सर. It is down. It is down.
नीचे कर दीजिए.
It is down sir. Comfortable.
हाँ बस ठीक है.
बस छोड़ दीजिए, कुछ नहीं करना.
और थोड़ा नीचे कर दें.
नहीं सर, ये ठीक है.
ठीक है. परफेक्ट परफेक्ट.
So now we take our first incision here. Few more things that I would want to say is do not try to touch the tissue by laser fiber. Stay slightly away. Okay, if you touch, it tends to make holes there. If you are slightly away, the plasma of the laser itself does the dissection. So the initial incision we will take here.
रेडी कर.
मुझे ये लो मैं. हाँ. हाँ जी बताइए.
Yes, sir. Ready.
हवा नहीं जाने दे भाई. एमिंग बीम बंद कर दीजिए.
ऑफ ही कर दो. ऑफ ही कर दो. एक मिनट. हाँ.
Ready?
Yes, sir.
Okay, so a lot of movements here are rotation movements. I'm keeping the camera stable and I'm just rotating my wrist here. We can already see this capsular fibers. So these are capsular fibers.
Right.
Okay. So we'll do the similar thing on this side.
Sometimes they say lateral lobes are, apical lobes are protruding
दादा
beyond.
खांसी मत कीजिए, बता के करो भाई खांसी. हाँ सर सर.
When the apical lobes are beyond Viru, then we have to cut beyond Viru also.
Yeah, yes. It's very, very routine to go even around a centimeter, centimeter and a half behind the remoter. So again, we can see the capsular fibers here. Okay. Now that I have identified capsule on both the sides, now I join the two incisions in front of the remoter. I join the two incisions here. Now I know capsule depth here. I know the capsule depth on this side.
Sir, just a minute.
There's a fiber group.
Fiber box. Just
मैंने बताया कि बंद कर दो.
इसमें निकाल लें.
निकालने का है, कोई रास्ता नहीं. सर निकाल.
सिस्टर फाइबर्स का रखें. उमेश कैमरा इस पे लगा.
हाँ जी.
थोड़ा सा. Are you ready?
Yes, sir.
नहीं कैमरा लगाओ इसके अंदर फिट
ऐसे
डाल दो डाल नहीं वैसे नहीं उल्टा उल्टा उल्टा
ऐसे
हाँ
इसके ऊपर रखेंगे इसके ऊपर
डाल
इसको सर थोड़ा
सर वो वीडियो से वो ऐसे बनेगा सर
कैसे वैसे करना है
सर वो वीडियो
हाँ तो कोई बात नहीं वैसे हो जाए ऐसे हो जाए
उल्टा उल्टा ऐसे हाँ जी यस
बस इसके ऊपर डाल दो इसलिए अब सब आपके पीछे से ही अलग है जो गलती से भी
हाँ जी करता हूँ ध्यान से
चले जाए रेडी नहीं हुआ ना रेडी है रेडी
अच्छा ऐसे करके ना वो खुद ही बोल देगा रोटेट डिवाइस अच्छा ठीक अलाउ नहीं होता ठीक
Now we can take the device. So this looks like a pretty cool food. So let's deepen this one.
फोन कॉल करके दूसरे डाला दिया
It's really important that don't do inside your life. Stay in the proper
Adi.
we have to go this deep. All this tissue needs to be cut. Now, some places here I can already see the capsule. So once I am at the capsule level, then I will start binding this incision. Like this is the tissue, these are the capsular fibers. This tissue part can be deepened further. I have to put that deep. ये सब करते हैं। This looks like okay capsule. Here there is tissue. Now once I have taken this incision, rotate your assembly. Again this remains straight. Turn this like this. So now I start looking from 6 o'clock towards 5 o'clock. So I go along the capsule and widen this cut into a trough. So when I do this, I should come and join the first incision. ये हमारा पहला वाला इंसिजन था, जो मेरे मॉनिटरम के सामने हमने लिया था. So widen it as much as you can. So if you are in the right plane, the tissue tends to separate very easily. This side separation is done. Now I will do the similar thing on this side. So I have turned in the opposite direction. Okay. Occasionally you will land with small capsular perforations here. In contrast to TURP, where we are extremely afraid of capsular perforations, small perforations may not be much significant here. HOLEP it is very common to have small capsular perforations because जितना क्लोज हम कैप्सूल के रीच हो ड्यूरिंग HOLEP, इट्स वेरी डिफिकल्ट टू गो ड्यूरिंग TURP एंड दिस इन दिस प्लेन. So it is all this rotation movements. Reasonably happy with the floor dissection. Now we can take the roof cut. So पूरा उल्टा कर ले, so that my this comes at 12 o'clock. Now again for the students I'll say we need to remember that the prostatic urethra is shorter at the roof than at the floor. The sphincter is not at right angle to the urethra. The sphincter is obliquely placed. So the prostatic urethra will be shorter at the roof and than the floor. So this incision should be just short of verumontanum. So ये हमारा verumontanum यहाँ पर है, तो हमें पूरा यहाँ तक नहीं आना है, 2-3 मिलीमीटर शॉर्ट रखना है. Second thing is you can always increase the incision. Obviously you can reduce the incision. So make a short incision and if you feel later on कि छोटा हो गया उसको बड़ा करना आसान है. ठीक है. Again the tissue at the roof is very less. So you will reach the capsule very fast. So in most patients there is not much tissue at the roof. So just what I am doing is keep on pressing it downwards, keep on moving back till you see the capsular fibers. We are nearly there. Maybe one more swipe and will be there. Keep this incision very short. There we can see the capsular fibers there. Okay, now once we see this, so this becomes the one limb of the T. Now I need to convert it to take the other limb of the T. So at this level, I will extend the incision laterally. And again, once you are on this side, rotate. So I start taking a transverse cut, come back, and once I'm back, I rotate a bit so that it also keeps on going downward.
Are you using manual pressure of the sheath also, sir?
None, sir. Absolutely none.
Frequency कितनी है? 40? 50 hertz.
So now we have dropped this from 12 o'clock to maybe around 2-3 o'clock. Similar thing we'll do on this side.
इसकी डिजिटल लिमिट कहाँ तक है सर?
सर इसको हमको शॉर्ट ही रखना है।
इसको भी उतना ही रखना है जितना रूम के रखना है।
हाँ बिल्कुल, और जैसा हमने कहा सर जितना कम रहे कोई दिक्कत नहीं है, बड़ा तो कभी भी कर सकते हो इसको। अच्छा, जब जब आपको ऐसा ब्राउनिश टिश्यू दिखे, दैट मीन्स यू आर गोइंग इन द टिश्यू। If you are in the proper plane, it should look white like this. Okay, so whenever I see brownish tissue at that place, I will deepen my swipe a bit. And this remaining brownish tissue can be fulgurated in the end. So now we have dropped. So now we have dropped this from above on both the sides. Okay.
शीट के अंदर है, शीट के थोड़ा
ये डॉट को मैच करना है। इससे अंदर ब्लड में चल जाए। हाँ हाँ, एक हमेशा अब ठीक है। So we have dropped it from the roof on both the sides. Okay. We have elevated from the floor. Okay. Now I need to join this point to this point. So this is my distal limit. Okay. You can make out this limit, sir. ये वेरिमोंटरम के साइड से हम यहाँ तक आते हैं। ये कर्व दिख रहा है, which could be the line between the membranous urethra and the prostatic urethra. Okay, here it is very clearly seen. We can see this line going down here. So I can deepen it a bit here. So the distal part of this roof incision, I take from the verumontanum side and then go forward. Okay, so we have dropped from above. Just थोड़ा सा इधर से ऊपर. Okay, once you take a mucosal incision, move forward and dip down. Move forward and dip down. So you will see this curve of the adenoma. You can see this adenoma going here. So my floor incision, my roof incision, again look at them. Okay, I will to join somewhere here. That's the mucosal flap that I need to cut. Okay, this mucosal flap will obviously, cutting this mucosal flap will not cause any incontinence. Once we take this, then we move forward and go along the adenoma that we can see. बाल्टी ले लो। हाँ ले लीजिए। एक मिनट हम बताते हैं क्या करना, रुकिए। इसको उस बकेट में डाल दो, उस बकेट में डाल।
बकेट में डाल
हाँ,
बस that's it. अभी रहने दो बेटा. This is probably the most hard part of the enucleation,
Yes,
sir.
yes, yes. So joining the roof and floor incision.
Yeah.
सब बिल्कुल थोड़ा थोड़ा करके कीजिए, सब थोड़ा सा ऊपर से नीचे ड्रॉप कीजिए, थोड़ा सा नीचे से ऊपर आइए। और हल्का सा टिश्यू अगर इस लेवल पर छूट भी जाए तो इट इज नॉट गोइंग टू कॉज एनी हार्म। You can see capsule quite good everywhere. You again look from below. So the aim is not to do blunt dissection. Means even when I push, I just try to stretch the adenoma so that I can see these connections better. Okay. Now once I see these connections, disconnecting these connections becomes easier. So always start from a place where you have identified the capsule. Like here, that's the capsule, this is the attachment. So start from here and go upwards. This, many times there is a tendency to keep on digging in between. Okay, यहाँ करते रहना सबसे आसान है. But if you do that, then the chance of you going inside the tissue will be very high. So थोड़ा सा हम ऊपर से इसको डाउन करेंगे, थोड़ा सा नीचे से ऊपर लेंगे. So the incision only starts where I have seen that. So that's the capsule. This is the attached tissue. Okay, again come from below. This is the attached tissue.
ठीक है।
Now will come a time when now we have flopped the tissue inside the bladder. So the weight of the tissue itself will now start pulling and we will see this attachment better. एक बार ये हो जाए then it becomes quite easy. Again, one very important precaution is once you come near the bladder neck, switch off the outflow, let the bladder fill a bit. So we want the orifice to move away because this adenoma, once it is flopped in the bladder, I have no view of the trigone. So I don't want a situation where I inadvertently go in and cut the, injure the orifice. And
That
also,
could be more a concern if you have a medial lobe.
large medium, yes. And also, sir, once the bladder is filled, means especially if the adenoma is large, you create some space for the adenoma also to go in. So now once I was near, I have just partially switched off the outflow, let the bladder fill. Do not let your fiber go inside the bladder. Stay here inside the prostatic urethra and cut from a bit far away. ये जो छोटे छोटे सब इनको जस्ट पुश कर सकते हैं. Now before going on other side, अच्छा इसमें we have the other foot switch of hemostasis.
So that's
Yeah. So before I start on the other side, I will just complete the hemostasis. Some of these threads you can just ablate them. So one look done. करेंगे सर दूसरा लोग.
Has it?
Small capsular formation.
इसमें ऐसा नहीं, इसमें इनको करने दो, पूरा दिखा
Is it
दो.
also common that PR syndrome?
नहीं सर PR syndrome नहीं होगा because we are using normal saline.
Dr. Pankaj,
हाँ जी.
you do this one
Okay.
because this is we are telecasting.
ठीक है सर.
So
Don't worry about the mucosal incision, sir. The moment you take mucosal incision, beyond that it is important to move forward. Because, so after the incision, we are continuously moving away from the sphincter. If we keep on moving forward. So you will, once you are in the right plane, the tissue will open up like this.
Away from the sphincter, and is your force going towards the bladder neck?
Yes.
Okay.
So, sir, I don't think I am really pushing the tissue. The dissection is happening more by the plasma of the laser energy. Slightly away from, so जो आप कैप्सुलर परफोरेशन की सब बात कर रहे थे, you see they say that in a standard HOLEP, the amount of fluid interstitial is around 600 ml for around 80 gram gland. Means in TURP the fluid interstitial comes to around 1.2 liters.
When you do this, ऐसा लगता है कि जैसे you're coming back actually.
Yes, अभी तो हम पीछे आ रहे हैं.
अच्छा पीछे आ रहे हैं.
अभी
But
तो
near the viru, you just go laterally and the force is towards the bladder neck.
Yes. So अभी I'm just
At the
elevating
neck.
this.
Now he's at the neck. He's just
Now he's at the neck. Yeah, yes, sir. Bloodless है बिल्कुल.
Yeah.
लेजर तो
I don't
यही.
know. I've seen many
छुड़वा दो
patients. There is usual bleeding. थोड़ा
हाँ, ये
बहुत.
तो
But in his cases, I don't find any
Yeah,
bleeding.
no bleeding at all.
Veins are opening according to his wishes.
बहुत बढ़िया सर. हाँ, बहुत ही अच्छा. मजा आ गया.
थोड़ा सा हल्का सा दिखना चाहिए.
एक खुल गया अभी.
बस yes.
तो जितना ये कम रहेगा उतना आपको प्रिसाइज
Vibrate नहीं होगा.
तो ये हमने म्यूकोजल इंसिजन ले लिया. अब इसका हमको कोई मतलब नहीं है. आई कैन सी दिस एडिनोमा गोइंग अप फ्रॉम हियर. Just go along the curve of the adenoma.
इतना फास्ट करेंगे सर तो 3 बजे तक करेंगे क्या? 3 ही केस हैं हमारे पे.
सर
आप जान करके स्लो कीजिए.
सर के साथ हमको करने को बहुत सारी चीजें हैं. हमें तो पिछले विजिट का अभी भी वो एक लेट नाइट वाला कॉफी का ट्रिप याद है.
I'm showing him Nahargarh from here. We went to Nahargarh last time.
ओके.
वहाँ के ऊपर कैफेटेरिया है ना.
हाँ.
Right away from the rotation and keeping the continuous watch over capsule. शुरुआत में हो सकता है आपको लेजर कैपिटेक्सी दिखाई न दे. So it will be better to use the evening beam. आपको लेकिन evening beam थोड़ा डिस्टर्ब करता है. लेकिन जैसे ये लेजर का लगता है. हाँ. अगर देखने को दिक्कत होती है तो ये use कर सकते हैं.
100 watts से ऊपर भी हो सकती है. So many people reduce the power as when they are close to the verumontanum. मैंने देखा आपने नहीं करी सर इसमें, है ना? Many people do it just to
हाँ तो
avoid.
I really don't think it really makes much difference. So now we have this very small attachment beginning. सर एक बहुत ही इंटरेस्टिंग पेपर पब्लिश हुआ था इन नॉट पेपर एग्जैक्टली दिस वाज वन पोडियम प्रेजेंटेशन इन AUA. What they did was they calculated the amount of time you remain near the sphincter during HOLEP vis-a-vis amount of time you go to the sphincter during TRP. And they said because after the cut you just keep on moving away from the membranous urethra. The time spent near the sphincter is extremely low.
लो. TURP में ज़्यादा है.
TRP में ज़्यादा
TURP, ठीक
है.
है.
आप करीब हर लूप के स्वाइप के साथ आप वापस membranous urethra तक आते हो.
I don't think it does it make any difference sir, because nowadays incontinence will also very rare.
Extremely rare.
Extremely.
Extremely.
You are thinking नहीं वैसे भी नहीं होता. HOLEP rather has a little bit of transient
Yes.
urgency and incontinence because
Sir, maybe I can tell you that it is possible to predict किस patient में होगा.
अच्छा.
Means a very frail patient, poor musculature,
Okay.
or say octogenarians,
Okay.
uncontrolled diabetics, and very large prostate.
Very large prostate.
So
And
these are the
prostates
patients.
which are protruding beyond the value also.
Yes, sir. So these are the patients where I specifically tell them that it might be there temporarily. We have started putting them on sphinctering exercises
Okay.
Before the TUR.
before the procedure. And the incidence is extremely low, sir. It's,
So how do you approach those cases in which the tissue is significantly inframontanal? For example, say that we have little bit of small lobes continuing beyond the viru. I mean,
Sir,
any change in?
no, sir, because you keep on working along the contours of the adenoma
Okay.
and don't worry about the verumontanum at all.
Okay.
So after the first cut which I take between the verumontanum and the lateral lobe, after that I barely see where it is.
Okay.
Having a proper outflow channel is also sir, very important, no?
Yes, sir.
I've seen many European urologists put in a routine SPC before OLEP.
Yeah, retus cannula जैसा कुछ डाल देते
हाँ वो
हैं.
कोई मोटा सा कैनुला डाल देते हैं सर.
So even Varshnava puts a large
Okay.
angiocath.
दो ट्यूअर है ना, एक ट्यूअर
Even उसमें Nadiad में भी routinely they are putting.
तीन है ना, एक हो गया.
Does it really
दूसरा वाला
is it really helpful? मतलब अपना ये glacier system do you think
सब हमें कभी ऐसे
कभी जरूरत पड़ी
महसूस
नहीं
हुई.
इसकी या it's good to have a good outflow.
दादा हिले मत.
Trigon. ये थोड़ा टिश्यू है सर ना या
Sometimes some nodule
Yeah.
चिपका हुआ रह जाता
And
है.
it is not always that it is very smooth capsule. Sometimes these small nodules enter into the.
फोसा का कोई कंपैरिजन नहीं है between a TUR and OLEP. There is no comparison of the fosa.
सर इस प्लेन में you just don't enter in QR. And even the say the risk of regrowth, they have just recently published around 2 years back a 18-year follow-up, where the risk of regrowth has been penned at 1.5%.
Do we have a study after TURP?
Sir, it is nearly 2% every year.
2% every year.
Yes.
Okay. So it was used to be said
So I think
5% in 5
Sir,
years.
some morcellata ready?
Morcellata, please.
So can we have a look at the sphincter? एक बार sphincter का दिखाइए सर व्यू.
क्या?
Beautiful.
ठीक है सर.
Wonderful.
Okay. So morcellation के लिए I'll need one more inflow with IV sir.
लेजर बंद कर दिया? हाँ 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 लेजर बंद कर
ये हम आपको लेजर वापस दे
दिया.
देते हैं. Ready?
Yes. Fortis है.
दे दीजिए, दे दीजिए, just नहीं मॉर्सलोस्कोप कौन सा लेना?
नेफ्रोस्कोप चाहिए था?
अच्छा तो हमको बाहर आना पड़ेगा?
मॉर्सलोस्कोप भी है ना ये सिस्टोस्कोप में डाल सकते हैं।
इसमें जाएगा
यहाँ पे आपकी वर्किंग चैनल स्ट्रेट होगी ना?
नहीं नहीं इसमें इस वाले में नहीं जाएगा।
नहीं नहीं इसमें नहीं जाएगा। इधर
एक अलग से हाँ मॉर्सलोस्कोप
देख लीजिए इसमें जाता है कि नहीं।
कई लोग बात नेफ्रोस्कोप डाल के कर लेते हैं।
हाँ वो कर नहीं इसका अपने पास मॉर्सलोस्कोप भी होगा।
यस सर वो उसका कल अडेप्टर जो था वो मिसप्लेस हुआ था इसके लिए हम नेफ्रोस्कोप
अच्छा अभी वहाँ से भी जा रहे हैं
इधर भी नहीं था इसका
इसको पकड़ लीजिए। हाँ
ये अपना ही है क्या सर? वर्किंग एलिमेंट
ना
अपना नहीं है?
अपने पास था वो बोल रहे हैं काम नहीं कर रहा। एक बार मैंने उनको कहा है निकाल के दिखाएं।
सर को दिखा देते हैं
हैं?
सर को दिखा
हाँ
देते
एक
हैं
बार अभी पूछने को कर लें।
ये तो रिचर्ड वुल्फ का लग रहा है।
उनका अपना वाला भी उनका है।
वही अपना वाला भी है। अभी तो एक
अपना
तो
ओलंपस का है शायद।
नहीं नहीं वो साइड
ये फाइबर लॉक कैसे होता है इसमें?
ये लॉक
550 माइक्रोन फाइबर इसमें लॉक हो जाता है ना?
लॉक नहीं है इसमें यूकेट में डाला
यूट्रिक
है
कैथेटर में डाला है।
यूकेट में डाला
यूकैथ में डाल रहा है।
यूकेट में डाला
तो वो आगे पीछे नहीं होता रहता जैसे जैसे करते हैं?
टाइट है वो बहुत टाइट हो जाता
अच्छा, वो tight।
है फाइव साइज में डालते बहुत टाइट हो जाता है
ओके
मैसेज आया था सर।
यस क्या बताओ क्या क्या वगैरह so Dr. Pankaj, so we are on our YouTube channel. Dr. Rahul is joined and he's asking what is the setting here. So the setting is 50 frequency and 2 joule. So it is 100 watts total. So we have Dr. Pankaj, just tell us exactly what you have done till now.
Yeah, so Rahul, we have in this machine we have we can choose two set settings. So I have one setting for enucleation and one for hemostasis. So for enucleation I use 100 watt, so 2 joules into 50 hertz, and for hemostasis I need low joules and low energy. So anywhere between 1 to 1.2 joules and around 15 to 25 frequency.
Thank you, Dr. Pankaj. I think, Dr. Rahul, you got your answer. So we are just trying to set the instrument.
Machine is what?
This is 100 watts. 100 watts. And this is a Zena machine coming from Germany. And we have this machine as a demonstration machine here in our department now. So Dr. Pankaj is putting the nephroscope so that he will be able to modulate the two lobes.
फिट नहीं हुआ कैमरा प्रॉपर्ली।
दोबारा कर
Right.
समय पर
Okay, I need one more IV set. So I need 2 inputs, like a porcelain to be.
इसमें तो बहुत कम जाएगा लेकिन आईवी सेट में तो वी कैन पुट अ क्यूआर सेट आल्सो ना।
उधर ऑन थोड़ा दबा देना।
So Dr. Pankaj has put the morcellator in the nephroscope. There is a separate morcelloscope also available, but he is more comfortable putting the nephroscope into the nephroscope, and the morcellator has been put in.
so what size nephroscope with or without outer sheath? If with sheath, what size?
What size nephroscope? The nephroscope size he is asking
24.
24 French nephroscope.
Yes sir, flow is there.
So you can show him.
Yes, sir.
So now the other one.
Other one.
What precautions one must take while modulating?
सब ये नहीं हो रहा है।
नहीं हो रहा है इशू आ रहा है सब कटिंग इश्यूज तो नहीं आ रहा है सर ये इश्यूज कनेक्ट
नहीं हो रहा है सर।
जो प्रॉपर सेट करके उसमें जाना चाहिए ना, वो सक्शन वाला इफेक्ट नहीं है।
हाँ हाँ हाँ।
हाँ
अभी
बहुत सारा
so the bladder seems to be collapsing. सक्शन कितने पे रखा है?
हाई क्या हुआ मीडियम तो
हाँ मीडियम।
दिस इज बेटर राइट।
The tip must be kept at the level of the bladder neck.
Yes sir. So basically I want the bladder to be overfull. Okay. Once I hold it in suction, means then I would want to depress my hand so that the tissue goes away from the floor and is in the center of the liver. So somehow वो जो ऐसा होल्ड करके उसको अलग ले जाना इसमें नहीं हो रहा है. So the moment I catch, I want to just
Inbuilt modulation है क्या
realize the bladder had collapsed from the side.
Yeah, first coming down.
Yes.
ये सर
थोड़ा स्लो कर दीजिए सर, कर दीजिए, स्लो कर दीजिए, देखा जाएगा. हाँ बस.
ब्लेड का स्पीड कम करना क्या सक्शन?
नहीं ब्लेड का स्पीड ठीक.
ब्लेड का स्पीड कम हो गया।
नहीं सर ये सही नहीं है।
देखिए
ब्लेड की स्पीड भी कम लगती है जो रूटीन या अपन देखते हैं मॉड्यूलेशन में। तेज कर सकते हैं ना उसको 18 से आरपीएम में तेज कर दो। नहीं नहीं ऑसिलेशन
RPM
स्पीड
ये ना स्पीड है। हाँ ये ठीक हो रहा है। स्पीड बढ़वाएं क्या?
प्लीज कोशिश कीजिए.
ये इनका मॉडरेटर है या अपना मॉडरेटर है?
ये अपना तो कुछ भी नहीं है।
अपना कुछ इनके ही है ना?
हाँ
थोड़ा सा ऐसे ब्लेड ब्लंट नहीं लग रही है?
मुझे इधर स्टक हो जाता है वो नहीं हो रहा।
हाँ नॉर्मली
Sucks into this.
नहीं कुछ तो भी मिस्टर ईश्वर,
और
कुछ तो
बढ़ाओ।
भी अभी भी सेटिंग में प्रॉब्लम है. अरे जो
ऑसिलेशन बढ़ा दो।
जो हमारे मॉड्यूलेशन में हमको मजा आता है वो नहीं आता है.
ऑसिलेशन बढ़ा दो। और बढ़ाओ और बढ़ाओ।
ऑसिलेशन 3 है। सेक्शन और स्पीड और बढ़ा दो।
हाँ बढ़ाओ।
देखिए आप देखिए लेट्स सी
पुश हो रहा है कि इससे सक होने की वजह
ये सक क्यों नहीं हो रहा है?
या
सक होना चाहिए।
सक्शन ठीक है क्या इसमें? सक्शन लग रहा है?
हाई इंस्पिरेशन
अच्छा।
वो तो गया है
हाँ, but अभी हाँ यूजुअली जितना फास्ट होता है
अपने लेके आएंगे अपने
हो तो रहा है एक्चुअली, लेकिन या देखो
सक नहीं कर रहा, सक नहीं कर रहा है ना, उसके ऊपर बैठना चाहिए ना, बस चेंज हो गया।
नहीं सर, ये तो नहीं सकते, I'm not able to supply. स्पीड तो कमी रखते हैं भैया, ऑसिलेशन 2.5
एक और क्वेश्चन है सर,
क्या है?
what is the advantage of using nephroscope instead of morcelloscope? Is the vision
Somebody is
better?
asking what is the advantage of putting nephroscope instead of morcelloscope?
So ideally I would want to use a morcelloscope. Okay, the advantage of using morcelloscope is that I don't need to change the sheath. And I really do not want to change the sheath, because any change in sheath, whatever time it takes, some amount of bleeding may start. So because here our morcelloscope has some issue, that is why we are using the nephroscope. बोलिए सर, कुछ बताइए क्या करूँ?
टिश्यू इतनी
नहीं
स्पेस
यार,
नहीं आ
इतनी
रहा
गर्मी तो हमें नहीं। हाँ, are we doing something wrong? What is happening?
Actually, we check it up. This is the ideal setting they said. But suction, that's what even I'm wondering. This is not happening.
Actually, it should stick over the.
Yeah, it should stay there. It is not
it should
staying
stay
there.
there. इसका मतलब सक्शन प्रॉपर नहीं है.
इतना मॉल के पास जाके कर रहे थे। What is this name? ये इनका I think सक्शन का नॉट ऑफ
एक जन
दिलीप जी का एक जन आपको बुलाओ बेटा.
वो तब टिक रहा है जब मेरा ब्लैडर खाली होता है. जब ब्लैडर खाली होता है मुझे म्यूकोजा की बस है. ठीक है. Whenever it has space, it is just running away.
That is like this one. Mucosa. So there is a risk of injuring the mucosa. So that's why you have to do it in full bladder.
So we'll take the 18 to weight catheter. 18 to weight.
18 French का 2-way catheter.
Angad. It is never, say, not a perforation, but it will be.
It's over, right?
It's okay.
So,
Okay.
so the morcellation has been complete. So it was 80-gram prostate. Dr. Pankaj has beautifully demonstrated the resection and laser enucleation of the prostate along with morcellation. There was some issue with the morcellation. Morcellation was a little slow, but we could manage it. So, Dr. Pankaj, would you like to say anything before we start the next case? Yes.
Just a minute, sir. I'll just put
Yeah.
the catheter.
Yes.
Catheter. Just a minute.
So he will just put a 18 French two-way catheter. There is no need to put a three-way catheter, and probably very little irrigation would be required, as the color is almost there is bloodless.
I think one needs to have more resistance for morcellation than enucleation. Chances of post-operative dysuria post-HOLEP.
Yes, so somebody is saying that morcellation has to be more patiently done than enucleation.
Yes.
Yes. Yes, Dr. Pankaj also agrees to it because you have to do it in full bladder. There is a chance of mucosal injury if it is done in not full bladder. So, yes.
And sometimes, sir, there are some tissues which refuse to cut.
Right.
Because there are some circular hard nodules which we call as beach balls.
Yeah.
They refuse to cut. They keep on jumping over the plate.
Okay.
Then in those situations, then you need to either use a rigid nephroscopy forceps to crush it,
Okay.
or maybe make small holes in that tissue with laser
Yeah.
so that it becomes irregular, and then you morcellate them.
Right.
So,
I just once Dr. Kocher said that he used to put it in stone punch.
Yes.
He would remove the tissue with the stone punch
yes.
in almost routine cases.
Yes.
So yeah, there are many ways to remove the tissue.
Yes.
That's post-operative dysuria.
What are the
So,
chances of
very
post-op
less, sir.
dysuria?
I feel that the dysuria mainly depends upon how much tissue we leave behind. Because we hardly leave behind any tissue, the dysuria is minimal. The dysuria is minimal. The risk of incontinence, stress incontinence would be very low. Urge incontinence will be there in around 10-15% patients.
And that urgency usually disappears
Within
by
3
what?
to 6 weeks at the most.
3 to 6 weeks.
Yes.
So do you
And
give
so
any
we can
medication?
see here, without any traction irrigation, the urine is absolutely clear.
Just see the tubing. It's without irrigation, without anything. It is crystal clear. So you cannot see even any RBCs there.
So, sir, the patient's comfort at the end of the procedure means
Yeah.
when you see him in evening, he'll be sitting comfortably, having
Yeah.
his food. So the comfort of the patient is very good.
Right.
Like whenever you put a large catheter with traction irrigation, there is
Right.
some discomfort to the
Definitely, definitely.
patient. And usually I remove the catheter within 36 hours.
Okay.
And
Yes. And again, usually what you had said the last time, that you remove the catheter at midnight,
Midnight, yes.
and so that the whole night he can sleep well,
Absolutely.
and in the morning when the bladder is full, he can pass with a full bladder. And we have also adopted that method, and we are really finding it very good.
It's very
so
interesting.
yes, very,
It's very
nice.
interesting.
So that's really good. So we can see the amount of tissue that has been removed. This was around 80 to 100 gram prostatic tissue, which has been morcellated. Yeah.
Sir, have you ever need of a bladder wash due to bleeding or?
oh, yes, sometimes suppose at the end of this would not have been clear. I have to put a 20 or 22 with irrigation. So it is not that every patient happens like this. This patient was very
So
smooth,
there was a
it is-
question that whether you want whether you require a bladder wash sometimes or not, or in irrigation sometimes. Yes, Dr. Pankaj. Yes, please.
Yes. So, sir, any patient who is on clopidogrel, I would definitely put him in a 3-way catheter with irrigation. Some patients, especially with long-term catheter, or some procedures do not go as smooth, then you put a 3-way catheter. But I would say 80% patients would go on a 2-way catheter.
Two-way catheter without any irrigation.
Without any traction.
Right.
So I will instruct for a good hydration, maybe Lasix at the end of couple of hours,
Okay.
and that should take care of it.
That should be. So you don't use irrigation at all?
In a lot of
Most
patients,
of the cases.
Most of the cases.
So you don't use.
Yes.
So that's a great thing. Yes. So I think we will take a break here for about half an hour, and when we have our next case, I will just send you a message that we will be starting soon. Right? So thank you once again. Thank you, Dr. Pankaj.
Thank you, sir.
You can just stop it. Pause कर सकते हैं.
म्यूट कर दो बस
Pause कर दो.
पॉज नहीं होता सर लाइव
बंद वाली. You can stop it.
म्यूट कर दो बस